Yes.
All right, so today we're going to talk about this peri-implant tissue reconstruction and replacement of an aesthetically failing dental implant. This was truly a multidisciplinary case. Myself, Dr. Progebin, Peter Rizia, as well as Jill Bailey, who's not here. She was the orthodontist on this case. So let's get into this patient and let's give you some history. Patient came to us, implants number 7 and 10 that were placed about 10 years ago. A number 10 site gradually developed some recession over the years.
Right.
She came, her chief complaint was just poor aesthetics. She was very aware and conscious about the aesthetic issue with the recession. This is the x-ray that she had initially. Implant, restoration, abutment. This was placed in Europe, so the type of the implant, I'm not really sure, but a different brand and brand name.
You can see the over-contoured restoration, which we'll see in a sec, and that's actually food impaction along the gingival margin, which contributes to the gingival recession. But for her, her major chief complaint was, I don't like my smile. And that's pretty much her smile. That's not a high smile, that's not exaggerated.
It's a very natural smile.
That is a natural smile, and obviously the restoration is in her aesthetic zone.
So full mouth series, nothing remarkable.
Pretty uneventful, healthy person, good periodontium, nothing. Yeah. So this is the critical part, and I want you to see. we're going to end on emergence profile and contour of not only the restoration, but the shared crown and abutment, both sharing the emergence profile. And as Hamid is showing you, right there is the critical over contour. Over contour of the restoration because the implant is placed so shallow. That's critical.
And incidentally, we see that there's actually a good alveolar bone. It seems like the implant was placed very nicely within the envelope of the alveolar bone.
Very
itself.
nicely for a surgeon, but maybe not so nicely for the restorative dentist.
Right.
And that's why the two of us are sitting here as the team. You know, this obviously is an unaesthetic restoration for her. And gradually, we're getting more and more of the metal of the implant showing through. So that's not only the abutment, or that's the implant body itself. The implant was placed in Europe, and we don't know the implant, we don't know the parts, company, or anything, which is presenting a problem.
So here we are. So this is kind of how the patient comes. So what are we thinking about here? So this patient came to me. I told her, I said, look, the first thing we need to do is get a restorative plan. We knew that certainly there's some challenges in terms of soft tissue, bone, position of the implant. But really the first thing all starts with a restorative plan. So what was the conversation that you had?
So for obviously the question is, can we keep the implant? What's bothering you? There were a couple of things that bother her. Not only was it that the metal collar was exposed, but that the tooth was so much narrower than the symmetrical tooth number 7. So really the width of this number 10 lateral incisor was only 5.5 maximum of the clinical crown. She didn't like that. So obviously a thought process is, would you get involved with orthodontics? Because orthodontics is going to set the site for us clinically, and it'll give us an adequate space. How much is the space that ideally I want? 6.8 millimeters, 7 millimeters. That's what I want for the width of lateral incisor. But there are a couple of surgical things to note. Surgically, this implant is placed perfectly between the buccal and palatal corridor there. Mm-hmm. But restoratively, it's not working for me, too shallow. But you can see on the CBCT, there is really good, adequate palatal bone. I mean, an abundance of good. Mm-hmm. And that will determine what our treatment options are going to be.
So really the challenge for me was how to regenerate the soft tissue and bone and replace this implant. And we'll talk about some of the treatment options that we actually entertain.
And the last thing I want you to note, obviously the CBCT is a given, but the periapical radiograph is showing us that she has good interproximal height of bone. So that's good. And I know that predictably, I'm going to get a good aesthetic result papilla-wise.
So our problem list is pretty clear. An aesthetic, poor tissue, thin tissue biotype, malpositioned tooth. This is definitely a tooth that is outside of the alignment of the arch, and maybe outside of the arch. So, because of the problems at hand, we needed a team. Obviously, with patients, it's very easy to jump into the problem at hand and saying, okay, we're going to address this implant, we're going to address this crown, we're going to make you happier. Yes, we can do all kinds of things. But to really kind of step back and sort of offer, this is an opportunity to really provide a patient with something more while they're undergoing this long treatment. And I think orthodontics is really kind of an interesting concept, which I wanted to...
But it's pretty amazing when you have to redo a failing or failed situation. It's pretty easy. You say to the person, now that they've done it that way, we have another way of doing it, maybe the right way of doing it. And 9 times out of 10, people are like, hey, look, I just want to do it right this time because this is our second round. And orthodontics was easy. She saw that, by the way, I have overlap on my central incisor, we have crowding, my lower anterior teeth are crowded, you'll see. There are issues, my bite isn't quite right. I can address all those things, and oh, by the way, I need space for an adequate sized tooth and implant. And she's like, look, let's go for it. Right.
So let's look at some treatment options. I think if we kind of look at recession around an implant restoration, what are the things that we can do? We can certainly do a connective tissue graft, restore the missing soft tissue defect, and maybe a new restoration. That's possible perhaps in some cases. Can you take the same implant, do a bone graft around it, soft tissue graft on the existing implant, and do a new restoration, perhaps in some cases? And the third possibility is the explantation. Remove the implant, restore the missing bone and tissue, and do a new restoration. So here we are. These are several different patients with recession around implants. There are all kinds of different ways and shapes that they come in, and we see this quite frequently in the aesthetic zone. And
maybe
it
too often.
Happens quite often, maybe too often. So I think the question is, what are the treatment options? One of the things that I had reflected on, having seen these cases, is that the treatment is really determined by a few factors. Let me tell you what I've learned. The treatment that we choose really is based on where is the implant, how much bone we have on the buccal area, the soft tissue thickness, and really the contour of the abutment restoration. Those are really the 4 factors that give us the information or data to decide which one of those 3 treatment options is appropriate.
I completely agree with you. And based on these, we'll determine what our treatment outcome is and what our treatment sequence is. So these are the 4 factors that are most critical to determine, can we save the implant, explant the implant, do we need to bone graft, do we need to soft tissue graft, does it just need a well-contoured new restoration?
So one of the things that's really important when we try to decide which treatment option to go is, I think, the question. The question is the implant emergence angle within the ridge envelope?
That's the first question you got to ask yourself.
Because if the implant is outside of the ridge envelope, the
it's
only
a
option
no-go.
we have is an implant removal. That makes it really easy to decide. But if the implant is within the ridge envelope, the next question is, do we have buccal bone? If we do have buccal bone, do we have crestal bone? And then we can start to see that there are potentially other options aside from implant removal if we have adequate bone present. Now, the idea of bone grafting around an implant with tissue loss is unpredictable. It's not necessarily always a successful outcome because of the effect of implant exposure, the biofilm on the implant.
Some in the camp say we could graft the crestal bone loss. Some of the camps say, look, you start to get periimplantitis and bone loss, that's a criteria for explant. But I like this critical thinking, decision-making tree. You know, what's wrong and what's the solution to the problem.
And of course, in some situations, we have complete over-contoured restorations. And if that's the case, maybe a recontoured restoration with a soft tissue graft might really be the solution.
And the best way to try that is with a provisional restoration, given all the other factors being okay. Yeah. So Tarnow and others have come to a consensus: when to save, when to remove, poorly positioned, non-restorable, too shallow, and too buccally positioned. That is like the #1 major problem, and the treatment would be to remove the implant. Some people say if there's any attachment loss or if there's any thread exposure. Some people say you could manage that or you could try to graft that. And the third factor is this person had this 10 years ago in Europe, and is the implant company still around? Or can we even get parts for a new abutment, new crown, and or there are now 250 implant manufacturers worldwide. With the pandemic and whatnot, how many will survive? And can we get the parts? So if you can't even get the parts for some of these implants, that in itself says it's time for removal.
So let's take a look at our treatment sequence. We put all this together and we come up with the following sequence. Hygiene, first orthodontics to kind of begin that process, creating the space we need.
6.8 to 7 millimeters on average for a lateral incisor. Remember, she's congenitally missing a lateral incisor. Now, tooth number 7, the other contralateral lateral, I'm not unhappy with, and neither is she. So there's no indication to replace it. Replace the implant, replace the crown. She likes it, so do I. And there's obviously, it's the correct width.
The next thing is to remove the crown and abutment, just to allow that soft tissue to self-regenerate itself, because we're going to need it at some point.
And I left decorate versus decoronate, because I just want to emphasize it's actually decoronate. And we'll show you that's an old concept.
Surgically, we'll remove the implant, allow the soft tissue to heal. We'll come back in a delayed fashion and regenerate the bone and connective tissue.
Much more predictable.
Meanwhile, while that's happening, the orthodontics is completing the space management and occlusion. So we're working actually concurrently together.
And that's really important. The communication between the oral surgeon saying, hey, look, it's going to take me 4 to 6 months for grafting. You have 4 to 6 months for more movement. But after that, and I'm about to place the implant, there really should be no more mesial-distal movement. You got to be happy with my 6.8 to 7 millimeters once I place the implant.
So surgically, we place the implant. From a process standpoint, we do a prototype restoration, reevaluate. We do have an endodontic phase that we'll talk about on an adjacent tooth.
Any adjacent teeth.
Right. And then, of course, the next stages of completion of the restorations, ortho, hygiene, and of course, just monitoring. Let's walk through this in terms of how we actually did this.
So I just want you to take a look at the occlusion here. And this is how she presented. You know, the incisors are overlapped, the lower anterior teeth are crowded, and more important than that, her occlusion isn't quite right. And just with a mirror, you can see that. She's in occlusion. We need the space, but we really need better cusp ossar interdigitation. So here you can see on this, and then lo and behold, through the magic of orthodontics, the teeth are lining up better, and she's got better posterior occlusion and anterior guidance, all done through Jill Bailey and excellent orthodontics, creating a space now where 6.8 to 7 millimeters, but again, better occlusion and better guidance.
So the next step is how we get the soft tissue back. So the first thing before really any attempt at bone tissue regeneration is removing the restoration and allowing that soft tissue.
Why is that so important? Why do you need that? What is it going to give us?
The soft tissue is really the key to closure of our planned bone graft. We need a good quality, thickness as well
Tension-free
as
primary
abundance of it.
closure. Yep.
So that tissue is going to be everything in terms of the not only the success of the implant, but also in terms of the aesthetic balance of the gingival line and everything else that we're working
So
on.
because she has inadequate buccal soft tissue, Hamid's going to want to do a bone graft eventually, explanted bone graft. If he can't get primary closure, his bone graft, it won't be as successful. But here, the key to doing this procedure, decoronation, is adequate palatal bone and adequate palatal soft tissue. That's how this thing works. Inadequate buccal, but you have to have good palatal bone and good palatal soft tissue. And then this can work.
So she gets an Essex appliance as a transitional, which is great. It
Or
works.
we put a tooth in her Invisalign.
Right.
Yes. And so people have called this, instead of doing a soft tissue graft, this is nature's connective tissue graft. But again, you could see an abundance of palatal soft tissue becoming the matrix for the buccal soft tissue to fill in.
So the next step, the oral surgical phase.
But this is also why this implant is placed good for a surgeon, not really, but inadequate for a restorative dentist. It's placed too shallow. That's the head of the implant that's exposed. So here we could see we need 3 to 4 millimeters of running room from the head of the implant to the adjacent CEJ of the adjacent teeth. We don't have that. And this is why this implant and the surgical placement is wrong. It's poorly positioned based on that.
So really the first step is for us to explant, remove the implant atraumatically. We use the reverse torque technique quite effectively in these cases.
How often does that work?
Yeah, we were talking about this earlier. The effectiveness of the reverse torque technique, in my experience, has been 100% on maxillary implants, D3, D4 bone for the most part, D2 in the anterior. For the lower implants, I would say highly effective, 95% plus. The only time that we have potentially a very difficult implant to remove with this technique is if you have a wide implant in a very D1 bone, in which case we have to do a little bit of a coronal ostectomy, kind of thin out the ridge by
Makes
about
it
2
easier
to 3
too.
millimeters, and then you can effectively remove it.
But there's not a lot of bone loss or destruction.
So this is essentially the technique that we're using for all implant removals, failing implants, implants with periimplantitis, or poorly positioned implants. Is really less than a 5-minute procedure to do a reverse torque technique. It's a special device that engages the internal aspect of the implant, and it can really back it out. What's really interesting about
Back it
this,
out cleanly
Back it
without
out
much
without
destruction of bone.
there is no bone cutting, there is no incision
But not
in
a
the
lot of
tissue.
bone loss.
And what's interesting is that implants that can be removed with this technique are totally integrated. This is implants that have been placed for years, which means
10
that
years, sadly.
that osseointegration is reversible.
Yeah.
Well, we'll talk
Sadly.
about that another time.
Okay,
Sadly.
that's like.
some PRF membrane just to help regenerate, maybe induce some biological regeneration of a soft tissue. 8 weeks later, we start to get a good granulation, epithelialization of the ridge, and the tissue starts to come back. And now we're ready for the implant phase. However,
if people only looked at the radiograph or scan on the right, and they weren't thinking restoratively, they would say, I have adequate bone volume to place my implant. And if we were doing implants 10, 20 years ago, I guess that's okay. But it's not okay now, because the marriage between the two of us is critical.
well, I think what can be very interesting to think about is a two-dimensional X-ray doesn't give you a whole lot, but with a three-dimensional CBCT, it may give a false indication that we have adequate bone for where the implant needs to be based on where the restoration needs to be. So when I was looking at this case, initially I was like, well, we do have enough bone, we might be able to do this. However,
This is
once
the however.
we do, this is, I think, probably the biggest thing that I can probably tell you I've learned in working out every one of the cases is before deciding or determining the treatment, we have to get more data, and you know, there's no way you can get that without doing a three-dimensional simulation.
So people talk the talk, but they don't always walk the walk. Meaning, it should be restoratively driven. By doing a virtual wax up or an imaging stat and saying, this is where I want the final restoration to be. And based on that, where's the implant position's gonna be? And based on that, is there adequate bone?
Right.
It's not just enough to look surgically. You have to look as a team together.
So we do the wax up, and I put the implant in the 3D model following where the restoration is, and I noticed right away that the implant is quite upright. It's there is enough bone for the implant, but not where the implant needs to be. So this was a clear indication that we can't do this. We cannot put the implant based on where the restoration is. So I think this is really
inadequate
groundbreaking
bone
for us,
based on where the restorative needs are.
which is kind of what we have been learning for years.
STL, DICOM, the marriage between the surgeon and the restorative dentist.
So no bone, no implant. We're going to go to grafting. This is a technique.
One miracle at a time.
This is a technique called a smart graft, which is basically a tunnel technique using vertical incisions on either side, which certainly resulted in a fairly good outcome in terms of bone initially. But some of this bone will resolve. This is the initial presentation. We have good amount of bone augmentation, and certainly what we want to see. Over the next 4 to 6 months as it heals, it does undergo through some shrinkage. We expect that. So when we come back to the second round to do our implant planning, yes, we do have enough bone to be able to put the implant, but I was still concerned about the over remodeling of the bone. Well, we like to have a minimum 2 millimeters on the buccal. If I can get minimum 2 millimeters, I feel good.
The absolute minimum. But I think that also depends on the biotype of the person. If you see through some of these CBCTs, you can only see the root eminence of the adjacent teeth. So she has a thin biotype. Given that, choose the absolute minimum. You really want 3 millimeters or more long term.
Absolutely. So yes, we can do the implant, but I already know that I need to do more augmentation. And that's what we planned. We'll go ahead and do the plan, our surgical guide in place. We'll place the implant using the guided technique.
That's a great picture. So there's absolutely adequate bone for implant placement. But long term, 5, 10, 15 years, is there adequate bone long term? Can we keep that bone long term?
Other thing that we can kind of see also, aside from the bone augmentation, is the very thin tissue biotype on the labial aspect of number 9, which was there from the get-go. There was essentially bony dehiscence on the buccal aspect of that. This is just shows the implant and the second bone augmentation. So this is an opportunity for us to take some additional amount of bone. This is mixed with PRF, laid out on the buccal aspect. I also did additional amount of micrograft material to really provide some more tissue support over the graft.
Just to thicken up the ridge.
Thicken up the ridge.
Both bone and soft tissue, both.
Exactly.
Long term.
And then PRF, we close this and let this mature for about the next 4 months.
Wow.
So we have bone, additional bone, which of course it'll go through some remodeling and shrinkage, but this will give us the outcome that we're looking for.
Long term, second round for her. Remember, she had a failed implant. So we want this to work long term.
Let this implant integrate, we come back.
You can never have enough soft tissue.
Never enough
Is
soft
that
tissue.
right?
So 4 months later, we do an uncovery of the implant. This is a palatally based incision to bring some of that keratinized gingiva and some of the connective tissue that we have there and roll it toward the buccal.
A pen. Yes, you're a grad pen.
And this is where you take over.
Yes, and another grad of pen, Arnie Weisgold, a master. Isn't it kind of amazing that there's not a lot new in dentistry? It's these old concepts that kind of resurface. And I think for crown contour and root contour, the perioprost from Penn were just masters, master clinicians. This is an old article by Arnie Weisgold. And basically, if you over contour a restoration like she had, you're going to get gingival recession. If it's flat or under contoured, that is the key that we're coming up with for decades now, then we're going to get soft tissue proliferation. So this is her provisional. It's going to be under contoured. I want enough soft tissue to sculpt and work with. So there are two concepts. Do I want to preserve if everything is perfect, or it wasn't perfect, so I'm going to have to sculpt it and regenerate it. But we run into issues because we have teeth and we have multiple surgery, and during this provisional phase, we really want to evaluate what is the vitality and health of the adjacent teeth, because we're working in a narrow spectrum here. So I'm going to have peruse.
First of all, you guys are doing a great job. It's great to be here.
Thank you.
I want to give the participants a couple of really tangible things to walk away with. Number one, I think before you do any type of surgery for implant, it's a really good idea to get a baseline for where the pulp of the adjacent teeth is. Maybe an endoconsult, maybe you can do a pulp test yourself. Make sure you're starting with teeth that have vital pulps and that you're not going to have a tissue necrosis in a tooth nearby affect your surgery. That's tip number one. Tip number two is in your consent for surgery, there has to be a mention that, listen, adjacent teeth can become devitalized no matter how careful we are. So the patient isn't sort of blindsided by that. Because at the end of the day, you have multiple surgeries. You're giving local anesthetic. You're using vasoconstrictors. You can easily affect the blood flow of adjacent teeth. And pulps are susceptible, right? It's a large volume of tissue with a relatively small blood supply. The way in is the same as the way out in terms of blood flow. Not good. There's no peripheral inner blood flow, right? That's not good either. And lastly, pulps are locked in the unyielding walls of the tooth. So they can't benefit from inflammation in the same way and recover from it in the same way as other tissues. So this lady came in and she had developed a pulpitis in tooth number 9, which was adjacent to all of the bone grafting, etc., which was done meticulously and beautifully. So because we needed to do root canal therapy because of that. But there's another consideration that I want everybody to be aware of. and that is this. When you have trauma to a tooth, the pre-cementum covering on the root surface can get denuded. Okay, now when that happens, there's an opportunity for a group of cells called odontoclasts to latch onto the root surface and cause some surface resorption. Now, that resorption, if there isn't any pulpal necrosis or inflammation, is going to be self-limiting. However, when the odontoclasts latch onto the tooth surface, if there is pulpal necrosis, the toxins would have traveled through the dentinal tubules, and that's a further stimulation for those cells to continue a resorptive process. So you don't want that. And for that reason, that was the second reason why we went ahead and did root canal therapy on tooth number 9. And the other thing that I wanted to mention is these days, just like everything else, we are very mindful of preserving as much tooth structure as we can when we're doing root canal therapy. So when you look at this post-operative radiograph, you know, it's extended to the radiographic terminus, it's appropriate in 3D, but we haven't sacrificed a lot of tooth structure. This is an important tooth. The last thing Hamid wants, and the last thing Keith wants, is to have to deal with another implant in this position. So we want to leave the tooth intact with as low a chance of fracture in the future as possible. That's really, you know, the main points that I wanted to get across on the endodontic portion.
Well, I think that's a critical point you bring up in terms of the importance of this tooth, because if we lose number 9, now you have an adjacent central lateral, which is a very, very difficult.
Well, I would think it's the
task.
most difficult.
It's probably the most difficult.
I think it's the most difficult.
Many people call it the dilemma
Yeah.
of central lateral.
That is not good.
And certainly because of the loss of that interseptal bone, and it's just so difficult to get a aesthetic
So
outcome.
I almost think you need to be proactive here. Yeah, whenever this happens, you know, either you do it or you have the endodontist do it. You got a vitality test, and you have to be critical. But the other aspect of that is because Dr. Zia believes in minimally invasive. I was only able to put a small restoration on the palatal surface, and that's it. So there is no veneer, there's no crowning. We're into preservation of tooth structure, and long term, minimal fracture, because the integrity of the tooth is saved. That's important. Okay, there are 2 articles. I know I believe in articles. I believe in science. It matters. So fantastic articles, fantastic. And the people here, this is Ernesto, this is the Perio people, Perio Pros from Penn, Arnie Weisgold, same kind of thing. This is now a 10-year follow-up to the original crown contour they call it subcritical contour, which is really the abutment or root, and of course the regenerative space. The critical contour is your crown, is your tooth, and the subcritical is your abutment or is your root. This is a 10-year follow-up on the original article. This was just published in International Journal of Peri Restorative. A fantastic article. In your lower right-hand corner, you'll see that they compared immediate versus delayed provisional. If we have a root replacement, the studies say you want to replace that root immediately. So therefore, we want the surgeon to make a custom healing abutment or component. What we've done for decades now is delayed, and we want to regenerate the soft tissue, as in this case. Okay, so again, I'm going to have to regenerate papilla, regional margin, all that by sculpting the provisional, by under contouring the final crown, and then scalloping the soft tissue. You can see, again, all the papers are showing that we want to under contour. We don't want an over contoured restoration, but on the buccal and on the lingual or palatal. But on the interproximal, what do we want? We want a shared emergence profile, interproximal, because from the contact point to the crest on a single tooth, we want to be 4.5 millimeters, okay? So in order to keep the papilla. This is the second article by, I think, the best people, and it's Stephen Chu, Joe Connor, Ernesto Lee, Layla from NYU, and Myron Evans from Boston, and they write a guideline on what the emergence profile of both the abutment and the crown in healthy patients should be. And routinely, everybody says on the facial or buccal, you want it to be concave or flat. Again, whether it's a tooth or in this case, the implant restorative emergence profile, IREP. Fantastic article, both articles in September and October of the International Journal of Restorative, Peri-Restorative Dentistry. So with that in mind, I want to take you through our journey. This is how the patient started almost 2 years ago now. And all these factors, we have overlap, we have inadequate space. Look at the root emergence, the eminence here. It's inadequate. So this is why Hamid had to do all that site development to make a nice eminence. You can go.
Mm-hmm.
Okay, that's a tri-end. I didn't like that. And it looks okay, but it's inadequate. I want a long contact area, but I thought the tooth looked too rectangular to me. So I sent it back. And I told the lab that facially, I want a more triangular tooth form. Right there. Right there. That line angle needed to be defined. But interproximal, right there. Interproximal, I want some color. And I want some warmth and vitality. Can you see that, surgeon? Mm-hmm. And so I sent it back, and that's what they gave me. On insert, I had a more triangular tooth form, but still kept a nice, broad, long contact area. And again, interproximally, I have more color. Here you can see at a 1 month follow-up, what are we getting? We're getting soft tissue proliferation around the new contour of the critical and subcritical areas. And we're getting soft tissue filling in. We're getting a nice semi-lunar free gingival aspect, and we're getting Furhauser papilla fill. This is now a 1 year follow-up. Look at the migration of the papilla and look at the contour semi-lunar of the soft tissue. It is ideal, all because the emergence profile of the abutment and crown were there. And we have good buccal bone and good interproximal height of bone.
One of the things we've talked about in the provisional state, and I like to use the word prototype more and more. And it's a term that we've been using a lot at the forum, and I think it means something more not only to me but also to a patient. What I tell them is that, listen, the restoration is not a temporary, it's kind of what we call a provisional, but it really is a prototype. And I think the amount of time and effort that goes into provisional / prototype is the key.
It is.
So my question is, how long do you wait? And to what degree do you have to modify it? And where is the pitfall in that?
So it's an excellent question. That's a whole. Biotype's a key. She's got thin tissue. How much surgery has she had done? How deficient am I? How close am I to my final endpoint? Determines how long I take, anywhere from 3 to 6 to 9 months. How critical is this? This isn't her aesthetic zone. I mean, this is her speaking smile. She's not even giving me an exaggerated smile. She's got a high, broad, gummy smile. So the bottom line is, you see everything, which is why I sent back the crown, which is why those little things make all the difference. Color, I wanted warmth, but it's not just color. I thought the rectangular tooth didn't fit her face well. I needed a more triangular line angle. And that made all the difference in the world. So it's not just the prototype or the provisional, it keeps on evolving and it keeps on working. And I think the more time you put into it, the more patients appreciate it. But then we're just talking one tooth.
Yeah.
To spend that much time, ortho, multiple surgeries, and multiple try-ins at the provisional, even the final state, to get it, that end product to be nearly perfect is everything. Anyway, so you could see it on a better shot. That's how we started. This is the try-in that I thought was good but inadequate, more rectangular, and I wanted more a triangular tooth form. And then you could see that's the money shot, is the 1 year follow-up. Nice, good shape and soft tissue.
So it's interesting that we see the abundance of the soft tissue on bone translate into really clinically of what aesthetically this case resulted in. This is really interesting.
Root eminence.
What's something that we also have appreciated more and more over the years, and there's been a number of papers on this, is the effect of the thickness of the soft tissue in the longevity and stability of the tissues.
And the implant, survivability of the implant. We won't get a fenestration, we won't get a dehiscence, we won't have peri-implantitis. We have, the whole complex has stability because of thickness.
And I think it's something interesting that I heard Maurice Salama say, one of the lecturers, was that if I had to choose between bone and soft tissue, I will take a thicker soft tissue every time.
Yes.
Even though we know that the bone is still of vital importance.
Right.
But that's how
you
much.
You did both here.
And we did both. But
both.
I think the critical thinking of building that thickness on the soft tissue is so critical to maintaining the bone, which is going to maintain and protect the implant. And certainly I think the aesthetic result, looking at this from 5 years, 10 years, 15 years, 20 years.
She's stable.
Why is it that some tissues don't move? They stay and they don't budge. And I think this is something that we've discovered more and more over the years.
So that's her beautiful, natural, normal, non-exaggerated smile. And you know, on the Furhauser score, we're nearly at a 9. We have level free gingival margins. That's hard just last week in October 2020. And you could see the papilla is completely filled. We have a nice semi-lunar effect of the soft tissue. And then we have fullness of the soft tissue. We have stippling, we have good color, we have good root eminence. And that warmth of the tooth. Good warmth.
So the fact that we have papilla filling in tells me that the distance from the implant platform to the contact
is perfect.
Is very good.
Very
less than 5 millimeters, because we have natural adjacent teeth to the implant.
And that's the key to keep that single tooth. Okay, this was the result of all these department chairs, and that article is the decision making. And again, if you could see the emergence profile, subcritical and critical, subcritical concave. But you know, Hamid and I someday, you know, we're going to leave it to the next generation. They talk about machine learning or AI, and I think at some point, machines with big data, next, will actually be able to tell us all this and give us computer algorithms for where to place, when to place, and give us outcomes long term. So at some point, iRobot is going to figure out all these criteria for us.
But this is really an interesting conversation, I think, with folks that come in who present for implants. And I think one of the things that may be overlooked perhaps is what type of tissue do you have? And this is an important conversation to have before you even touch a patient.
Oh, totally.
How much time should we spend talking about the potential risks of this? And I think people, well, we need to understand that and be able to relay that.
John Coys was the first one to identify this, and he published many articles on, and it's not just biotype, it's tooth shape, it's a high osseous crest. There's a whole criteria of risk assessment. And again, I would rather take a thick tissue person. I'd rather take square teeth or rectangular teeth. And in this case, she was a high-risk person. And then not only was she high risk, she had a failed implant. So that's why all these surgeries were more than indicated. Not only to get a good outcome now or 18 months, but she's young. I'm looking at 10 to 15 years down the road. And that's why we did everything possible. Ortho, multiple surgeries, and again, you know, we got a nice outcome, but she is a high-risk person.
Let's, we have a couple minutes. How about size of the implant? Lateral incisors.
Yeah. Big is not good. Big is not better. Big is not better. We've learned. Big is not good. And why is big not good? Well, as a surgeon.
Well, for a period of time, there was a trend that, you know, for central incisors, we were advocating 5 mm wide implants to try to mimic the diameter of the root. And I think we soon realized that that would encroach to the bone, the soft tissue, and of course, potential issues.
Bigger the implant, the less bone.
So we have gone back to standard size implants for incisors, for canines. And for lateral incisors, we have certainly narrow
3.3
size, 3.3. There's 2.9. And that's as thin as we have it right now, is a 2.9. And I think from an orthodontic standpoint, you pointed out to this.
The 2.9 is a problem. As you get to the smaller diameter, we have issues with that, prosthetically and both the implant itself. So going too thin is also a problem. We don't have all the restorative components from all the implant companies. And they do have a higher incidence of flowering, depending upon, you know, the internal connection. So 3.3 is our sweet spot. 3.4, 3, anything less than that, we got issues.
So that means that we gotta have 6 mm of space.
6.8,
and you cannot negotiate that. That's
can't.
it.
No, but that's why guided is so critical. Guiding. You want to place the implant where I need it.
Well, I was having this conversation earlier with Keith about the resorption and the buccal aspect of this tooth earlier. And I know that when we go through invasive bone grafting procedures, we're essentially creating a subperiosteal flap around teeth. We're raising the flaps, and bone and roots are there.
Thin buccal cortical plate, roots are exposed, one way in, one way out.
So I think the question is, how prevalent is what we noticed, the root resorption on this patient from adjacent tooth? Is this something that's, have you seen this reported in the literature? To what degree has this been something that you've seen?
It's not a big issue, especially in the hands of surgeons like you. As I said earlier, it's really about whether we denude the pre-cementum's covering of the root or not. So, and really the main take-home is for surgeons who are working, the less you violate that, the better. So these days, I was listening to you guys talking about guided surgery. I was talking, you know, tunnel techniques and minimally invasive. Whatever you can do to not denude that pre-cementum covering of the
That's
root,
important.
Yeah.
You're good to go.
Yeah, unfortunately, it's very difficult to predict that on a cone beam CT scan because we know that the buccal plate is thin, 0.5 millimeter to millimeter in most cases. And looking at the cone beam CT scan, you get an artifact, you get a false sense of that there's actually no bone, even though there might be there, but it's 0.5 millimeter. So
but you've done some really good cases with not laying a full thickness flap. And we've identified on cone beam concavities. Concavities and addressing those concavities. Now you think, no problem. It's easy. Okay? But that's because we've evolved and we've done so many of those cases where you isolate the problem, we have a bone deficiency in that area, and you address it in that area versus laying a big full thickness flap that you may not need to do.
Thank you both for sharing your thoughts. I hope that this was worthwhile for everyone who watched us today. So if you have a case that you do want to review, a difficult case or a challenging case, you can go to our website, facialart.com/case discussion, and you can actually, schedule a time, send some information. I'm happy to take the time and review and shed some thoughts, something that might be helpful for you when presenting treatment plans to your patients. Thank you. Thank you for joining us. We will be here again for the next complex case discussion series in first week in December. We will send out notifications and look forward to having you again soon. Thank you very much.
Thank you.
Appreciate it.